with the osteoporosis setting in. So we'll just talk it out. And I do feel, and nowhere in the pain medicine there is such an amount of relief to the patient, dramatic relief to the patient, that I was just talking to the answer from bench to wrench, and your patient comes in a stretcher and goes back home walking. So such is the beauty of the procedure. So I think let's talk it in detail, but it's very important to know it day in day out, because doing it wrong will be a disaster. So it's as dramatic is the positive result, as dramatic is the negative result of the procedure. So it's good that we take nuances, all the intricacies of the procedure and detailing the procedure, so that we do it right for a benefit of the patient. So this is, and I'm going to talk about the vertebral plan, I'm going to talk about the burst fracture, I'm going to talk about how do I do a balloon, anterior space balloon along with the kyphon balloon, and how I've done about 6 level vertebroplasty in one go, which was the world record initially in 2010, and then others have done more. So we're going to talk it down the line. These are the high end of the procedures. This is the fact of the matter now. Let's talk very frankly. What is happening is, we are at this time is about 2020, and more time passes, more people are with age 85 and over or 65 and over going to be there in the main population range. Look at this million people, so many million people. Not only in USA, even the developing countries are also having a age expectancy increasing, and more the age expectancy, more is the morbidity and disease and age related phenomena and problems coming in, and osteoporosis being one of the very common problem. So we have to address it now. This is typical of this age related issues. And the fact is that as the age increases, the chances of having a vertebral fracture increases to the extent of 75% or 70-75% in the age of 95 and age and plus. But suppose let's take it 85, which is in Japan and USA already. We have 50% of the patients who have a radiological fracture. They may be asymptomatic sometime, but then over a period of time they have collateral damage coming in and they start getting more symptomatic. So this is the amount of magnitude of the problem. This is how it is, like low back pain. And this is 15.6% of all ladies in their lifetime will have a fracture of the spine. And this is known thing. This was in 2002. And we can expect this is already increased. It was 700,000. I have checked data today. This is 1.4 million already. People are having each year fracture in the USA alone. And let's not talk about the world. World is such a big deal then. So the indications for vertebroplasty is, that's why we're discussing all this now. And it's so imperative. Over a period of time, you realize how important it is to do vertebroplasty in given set of patients. This is the 83% will be having a problem with the senile osteoporotic compression fractures. And there are about malignancy patients will have 3% will have metastatic fractures, and they may be a primary, maybe secondary. Mostly it is a secondary. And being 33 vertebrae, there are so many skeletal mats which give a problem to the patient. Multiple myeloma is one of them. Here the beauty is it is a correctable, curable disease. When you do a vertebroplasty in a metastatic one, it's a more a palliative one. But here it is a curative. So you have to kind of adjust accordingly. We'll discuss that in due course of time. And aggressive vertebral hemangioma, that's where actually vertebroplasty was started in 1984 by Dermond and other people, and that's in the cervical C2 hemangioma, aggressive hemangioma. And they were thinking what to do with hemangioma. You can't operate, there's no screw C2, so they put in a drop of cement and it embolization, just for embolization, and it worked very well. So that's how it started. It was a discovery by, you can say, by accident or by trial, and then it became very popular amongst Europe after 1984. In 1993 only it started in USA by Jensen, and now USA is doing more vertebroplasty than the Europe together. And now there's a vertebral tumors, avascular osteonecrosis is another problem, and that's where there's a gap in the bone. We'll discuss it. And the strengthening of the vertebral body before any major spine surgery, especially in osteoporotic setting, in age population, senile osteoporotic patients, any surgery they want to do for fixation or something, they strengthen the vertebra first and then they put in, because they have to have a screw purchase, otherwise screws they come out, and that's another reason. And it has been extended into the traumatic fractures in the polytrauma setting. This is what I was saying. Aggressive vertebral hemangiomas, it has to be painful, it has to be aggressive, it has to be dangerous. Then only you cement them. Otherwise, there are incidental hemangiomas, you don't touch them. You leave them alone before they become really bothersome. One more important point here is, sometimes these hemangiomas, they have a fallout in the epidural space. So you have to be careful when you're doing the cementing for these vertebral hemangiomas, that you are not putting a cement into the epidural space, so that can cause a neural compression. You have to be careful on that. And this is, I told you, metastatic spine is very common place where you have all these mats coming. And these mats are sometimes dangerous, because if it collapses, it can cause a cord compression an issue. Although it may be contiguous tumor spread into the spinal canal, which can cause problem. So that's a different story. But if there is a collapse along with that, you will have to manage that collapse part, and there are new treatments coming. We'll discuss it in due course. And this is, I told you about the strengthening of the vertebral body. You're trying to do something here. If you're not put a cement in these places, these screws won't hold. The bone which can't hold by itself, how will it hold those screws and another extra weight on these things? And that is important. This is a beautiful thing that people who are doing all this spine disc procedures, when they're doing hybrid procedures, and they're trying to put screws and implants into the vertebral body, if they find it osteoporotic, like in older age group for sure, what they're doing is they're putting needle right through the end plates into the bone, vertebral body, and putting cement first, and then putting all these screws. So instead of putting another vertebroplasty thing in there, either you have a cannulated screws which have got a cement injection devices, and it injects cement through the screw. That is one aspect, cemented screw, but they're costly. Other thing which they want is cheaper is they put a needle through the end plate, cement inside the vertebral body, and then put the screws and fix it. This is another very intelligent, very intelligent. This is, as I said, the communal osteonecrosis, you feel very happy. You find a void in the bone, and there is air phenomena in the lateral X-ray, especially in the extension. Oh, good, I want to put in cement. But there's a hindsight to that. And the hindsight is they found the studies that these vertebral blocks which you put inside, the cement blocks, if they don't hold well with the bones, trabeculations, or they don't integrate into the trabecular systems, they tend to be free, and then they can lose out and they can go out. So one has to be very careful when you get these kind of things. When you're putting cement end block, you have to make it sure that it has to interdigitate with the vertebral body itself to hold itself there. Otherwise, it might migrate. This is which I said, is senile osteoporotic ladies, and sometimes they're steroid dependent, medicine dependent, and they have osteoporosis coming in for other reasons or deficiency disease, and this is a common issue, and they have an empty bone phenomena. And this is something, and sometimes they have a fracture with a very trivial trauma. They don't even remember what caused them the fracture, but you have a radiology evident fracture, and this is painful also, but they don't remember sometime. Or a little trauma can cause the problem. This is the Dennis theory. This is the anterior column, and there's the middle column and the posterior column. And it is important to know, if you have two columns gone, this is single column, you have a stable fracture. You can simply cement. And if there are two columns, you can still go and cement, but it's little unsafe. If all three segments are gone, it's surely unsafe, and it needs a fixation device. But for anterior column reconstruction, if you can manage anterior column reconstruction and posterior is intact, your middle column will heal over a period of time. The theory is you start working cement from anterior to posterior and stop somewhere in the posterior 1/3, and that is where the strengthening of the bone is there. And typically biogeometry is when you just see how much is the wedging, and this is the anterior loss. And when you find the anterior loss is this much, or you have a corpse angle coming in and it's more than 15 degree along with the osteoporosis, or more than 25 degree by itself, these are the patients you have to cement, otherwise you have to do instrument, you have to do surgery, otherwise you can leave them alone. And very good medications are there these days, all these anti-resorptive medicines and bone forming medicines, and they can tend to heal most of the time. Times are changing, but there are number of patients who just land to us with like this, and it's a very bad thing to happen with anybody, that if it's totally collapsed, if patient is complaining with back pain, not realizing how serious this can be there if this kind of falls into the spinal canal. Or another thing one has to remember, this is called a cascade phenomena. Because this is collapsed, there is an increased mechanical pressure on the adjacent vertebrae, and obviously if they are osteoporotic for some reason, like in this patient, this patient had a 5 previous fracture, healed, the 6th fracture came up, for 8 months didn't heal, patient expecting it to heal, but yes, patient is aging, osteoporosis is setting in, and some fracture can be more pathological than the other ones. It didn't heal, and most importantly, this was at the dorsal lumbar angle. The dorsal lumbar angle, there's a maximum loading at the D12L1 area, because the dorsal area is fixed with the ribs, and the lumbar area is easy because there is a lordosis. It is only the DL junction where there is the kyphotic angle comes in, and this more unstable and more loading is there, and the more chances of fracture happening at this level. And this is what happens. This is what is influencing the cascade. This is the bone properties. There's so much to do with the bone properties, and there is something like neurophysiological property of the older age thing. The muscle, another thing, and patients bedridden, all those things come in, or comorbidities for that matter here, diabetes and other problems. and then you have a spine properties like a local spine issues or global spine issues. They all put together cause a problem. And it is said, if patient has got a osteoporosis and has got a one fracture, chances of having another fracture is 5-folds. If patient has got 2 fractures or more fractures, chances of having another fracture is 12-folds than general population. Look at this. If patient has got 2 or more fractures with 33% of the bone mass loss, patients having 75-fold chances of another fracture. There's every likelihood the patient will have another fracture. The whole moral of the story is, if you find a patient in fracture in osteoporotic setting, you have to treat osteoporosis. That's a primary disease. The fracture is a fallout of that primary problem. So you have to manage that part. So this is important to understand. It is seen sometimes fractures do heal radiologically, but patients keep on having chronic back pain because of the change mechanics. The myofascial syndrome comes in, or the facet joints start bothering, or there's a microfracture going on in this osteoporotic bones, so they keep having this pain. It is said 45% of the people who have healed radiologically can still have a back pain, and they remember their fracture for that matter. What I'm trying to say, they remember their back and fracture and their exact years, or they keep on having a multiple fracture one after the other for simple reason the angulated spine cannot hold itself and it keeps passing load on the thing, and poor vertebra, which was the original fracture, just keeps getting more and more collapse. So there's always increased wedging, collapse, and neurological consequences. Worry is if you start pressing on the cord, obviously there is a problem coming in, and patient getting more and more osteoporotic. Do treat osteoporosis, again the word is. Here is what I was saying. The fracture numbers are most at the L1 level. Yes, D12 also. D12, L1 are the ones which are getting most often affected, and you better take charge of the situation here because they have a dorsalumbar angulation and they have more loading, and they tend to collapse more and get more deteriorated. And by the way, at D12 there is a cord. So if it deteriorates furthermore, the cord conus is there, and the cord is there, and it kinds of getting compressed. Remembering, fragility fractures are a mechanical consequence of a biological disease. That word has to be remembered. It is a biological disease, osteoporosis, which has to be taken care. And again, reiteration of the same thing. Number of fractures will have more chances of having another fracture. Very clear study. The new vertebral body fractures, 7, 15, 21%, depending on whether it's a 1 previous fracture, 2 or 3 1, which I said a minute earlier. And that is why you have to treat. Now, luckily we have some good medicines like teriparatide. It is a very, very good. It is a bone forming medicines. If you give it, you can give it for 24 months, and it's a bone forming. It strengthens the bone and it can increase bone mass up to 15-20%. Bone mass is increased, and more so at the lumbar spine. That's the best part. Yes, it does happen in the hip and femur neck, but it is the maximum benefiting in the lumbar spine. That's the lucky point here, and we have to do it. But sometimes you can't give it whether it's a primary hyperparathyroidism, or there is a urolithiasis, or these kind of patients, or there is a chances of a malignancy for that matter. It was already litigated for that point of view, that it can cause malignancy in some patients, and that is where you cannot go for long, and you cannot give it beyond 24 months. That's the limitation about the teriparatide. And this is what the two mechanics are. This is bone forming, we are talking about the teriparatide, but there's another molecule which has come in, which is making very good help to the patients, is the anti-resorptive drugs which is there, and denosumab is the one which is really helping, which is anti-RANKL, and this is causing there's a resorption of bone. The osteoclasts are eating up the bone, so it stops the osteoclast, and the osteoblasts are activated by the teriparatide. So put together, you have a combo when you start with the teriparatide, and after once you're done with the teriparatide, you give either interval therapy with the denosumab, anti-resorptive medicine. So you have a very good bone health, and that is how the plan is. You give teriparatide for 18-24 months, then you can switch on to bisphosphonates for 5 years. There is a problem with the osteonecrosis of the jaw. That's a problem sometime, or sometime it is about a GI side effects. Patient doesn't tolerate it. So that's another thing. Or you can go with the denosumab, which you have to give once in a 6 months, 60 milligram subcutaneous injection once in 6 months, every 6 months. You can go for 10 years, safe, very good safe, and it can be used even in the renal disease patient, like with teriparatide it can't use in the renal disease patients, and that can be really used. And that is about the teriparatide is about 20 mac everyday subcutaneous injection. So the compliance issue is there with teriparatide, and sometimes it doesn't suit some patients, so that way you get into catch, but otherwise it's a very good medication. Mostly it is well tolerated. In all case patients, you have to manage with the oral calcium along with the vitamin D. That has to go side by side, and that is a lifelong thing. You have to start now and carry on, even in spite you stop all this. This is to be looked at. The plan has to be changed. The natural history of vertebral fracture is that if there is a fracture about 100 patients who are non-operable, one is operable, bad, you have to operate. It said 2/3 of them the pain will reduce in all these patients, and within 4 weeks of injury. Good, plus, very good. But that's a normal healing. Other ones will have normal healing 63%. I am happy. But there are 37% patients who have progressive collapse. Of these, there is a collapse healing in 23%. Remember, there is a collapse and then a healing. Now there is a change angulation now. Now you are already having a load on the adjacent vertebrae, and they can cause a chain mechanics. I manage these patients differently, I'll tell you. Or there is a pseudoarthrosis in about 14% patients. Not good to have this. And you don't know which one will have this. That's a problem. And there are some factors I'll discuss. And of these, 3% will have a neurological consequences, injury and sequelae. So please, you don't want this to happen in any case. And beyond that, look at the quality of life. Look at the quantity of life. Everything has to be counted. And so that's it. Beware, delayed collapse and neurological deficit will be burst fractures in these patients, pseudoarthrosis or ligamentous injuries, instabilities. There you have to be more careful, all these patients. Yes, it's a downward spiral. Please understand, all these patients who are old, senile, like our own parents, grandparents, and they're going through all this phenomena with the increased mortality. Age-related increased mortality, again and again there are studies which said, and not only mortality, the morbidity and the life quality goes down. And look at the times. Everybody is so busy, except corona times lately, everybody has been so busy all life, and you don't have big time for the old people there, and they're bedridden. If you don't do something, they're bedridden. Either you don't operate or you don't do cementing, then you have to manage them conservatively. There are issues, I'll just explain. Although I would like patient to be treated conservatively as much as possible. Look at this point, risk of mortality following clinical fracture. The maximum mortality risk is with the spine fracture. Then comes the hip fracture. That is something you have to be careful. There's a relative risk. And that is said, over a period of time, if you don't treat them, you have a more mortality. If you treat them, you have a lesser mortality. I'll explain. And if you put them on bed rest with the pain control, obviously you have to manage braces. There's decreased activity. They are on bed, and given age, older age, if you put them on bed, they have a inertia, and when they're bedridden, they have a more of osteoporosis setting in. And all this increases the vicious cycle, puts on the vicious cycle. Yes, painkiller, very good. But there are issues. You have renal issues, gastric issues, the CNS effects of the morphine, other drugs, and this all is there. And they are already a handful of medicines every day they're eating with for other diseases, and you want to add more medicine to that. It's not a great idea. Or you put them in very good bracing, tailor bracing and other all. So sometimes they're not very happy, these people, old people are not very happy with these braces. Young patient, yes, I can understand. Old people, they're not good and they're not compliant also to this. And especially in osteoporosis, when it is not healing, is bad. And look at the beauty. This is the old Greek or Roman times when they used to treat fractures. Look at this fracture. They are doing a traction and they're doing lordosis. And what intelligent thing. They didn't know anatomy and they knew the treatment part. And ideal, very right, very good on those times. And same I use sometime when I position my patient for vertebroplasty. I'll explain that. So I say, fix the fracture, don't fix the patient. And if you leave them alone and then the chronic pain, then what you're seeing is it gets centralized pain. So what is there, it gets cemented in the brain. And I say cement the bone, not the brain per se. There are patients who have a habitual osteoporosis or habitual fracture because of the pathological osteoporosis. And this lady keeps coming to me every 6 months or 1 year with a new fracture. In spite of she is on Posterior, in spite of she is on denosumab. So they have this pathological problem, and you are trying to maximize, but they keep coming with the fracture with the pain. You not much of option than just to put cement. So this is such a common thing, and she is about 79. So this is happening, And another thing is just X-ray is not enough. Sometimes what you do is patient comes, you get an X-ray. X-ray looks rosy, good. Like this X-ray is looking rosy. Leave them alone, and you find in about a month's time when patient was taken for another thing. I'll show you another shot, and it's totally collapsed. And X-ray will show a fracture here. Actual fracture is this, painful is this. If you look at this was looking a fracture as per X-ray, but the painful one is this. So don't leave it alone to the X-ray. If you have any doubt, go ahead with the MRIs, because you don't want to miss on fracture. You don't want to delay the treatment part. If patient is complaining of pain, especially turning in the bed, especially forward bending. Right, and these are the images which we do. This is actually T2, this is T1, and you have the morphology show up here, the pathology will show up in T1, and the stir will show the age of the fracture. So this is the picture. You should always get this done. And look at this. Now these are the ones which are fresh ones. This is the one which is the old one. Sometimes you don't pick it on T1, T2 images, and that is how it is. The fresh and old ones. And you have to treat the fresh ones, obviously. Not the old ones, you leave them alone mostly, if they are healed already and sclerosed already. Sometimes you need a bone scan. For simple reason, there may be tuberculosis, there may be pars fracture, or there may be mats. So this all is, in India we have a pot spine, such a common thing, such a common problem. So we tend to have all this with us, and not to take any chances with them. If patient comes out to be a tubercular, start with the ATT, send them to chest physician. MATS, primary work is oncological workup. Although you are going to cement them for pain reasons, now the reason changes. It's more of palliative now. And if there's parts, obviously you have to manage in a differently way. So this is important, and sometimes you can pick these things even with the normal MRIs. Recent imaging. The idea was, you have this patient coming in a month's time, and a patient came to me for cementing. I tend to have fresh MRI close to the day I procedure. Fresh MRI or CT for that matter, close to the procedure. Look at this is collapse. Now the treatment modality changes. There is a retropulsion, there is a posterior dehiscence. Obviously, look at the posterior dehiscence, that the modality changes. And another point which I am trying to bring up here, that patient has got a lesion here also. Respect that again. Patient has got a problem to do with that also. You have to manage that part. Sometime this patient came to me with the fracture. You can think of cementing, okay, fine. But look at this. There's a large psoas hematoma. Now this patient had a polytrauma setting. Obviously your priority changes. You're going to look at this first. Was the patient antiplatelet, any other drugs, and you have to look at this, and this needs more care. Suppose there's any abdominal injury, visceral injury, you have to take care of that part first. So that is, priorities have to change. Although for me cementing is the easy do. And I tend to kind of at least fix the fractures and take the other things also along. But you have to keep that always in mind when you're doing all this. I tend to get a 3D CT done for all these patients who are going to operate or do my procedures, because that gives me a very good external look of the morphology, fracture morphology. Although I have a CT also, and I'll explain that I spend a lot of time in the scan room with all these patients who have to do cementing. And I plan my trajectories, I look at the pedicles, which pedicle I'm going to go, right or left, and what will be my direction, the pedicle. If you look at this thing direction, you might go straight in like this, but look at the dorsal pedicles. Dorsal pedicles are down sloping. Look at this, down sloping, and they are placed higher in the vertebra, in dorsal area. In lumbar area, they can be right somewhere in the upper half, but here they are just at the top. So you have to angle like this. So this I'll explain you. This is, surgeons, they do good job. But look at this old morbid patient, comorbidities, and once there's anesthesia unfit, PSC unfit, where they're going to operate, and when you operate, there are some issues with the post-operation with morbidities. And if it's nicely operated, then you have a transition syndrome coming in. And then the bigger problem comes in. The screws loosen up. Because the bone is not holding the screw purchase is very poor, so sometimes you put a cemented screw for the same reason. And this one patient has got a pseudoaneurysm, because this screw is impinging on one of the vessel and it's caused pseudoaneurysm. Very, very good depictive case. Or implant failure. This rod has gone broken actually. Somebody did a good job, but rod is broken in 2 sets. Again, the bone is collapsed back. Now you have to start with something else. Another such patient, 3 previous surgeries. Cementing, another cementing, something went wrong, they do laminectomy and fixation. If you are very careful and if you watch very carefully, look at the cement, it looks okay, but look at this. This is in the epidural space. Look at the postvertebral margin. This is postvertebral margin. Cement is epidural space. Patient was symptomatic. So we did a spinal cord stimulation trial. It really didn't work in this patient. So patient was to be posted for another surgery, that is 4th major surgery, redo of all. And sometimes, yes, stimulators do help in some patients. Some set of patients, not all for that matter. Choose your patient rightly and wisely. Somebody did a cementing. Enthusiast, fine. But look at this, pedicles are all gone. This patient can't sit now even. Although somebody must have thought this may take the load. If you have not done a good filling anterior column reconstruction, and this is not taking the load of the spine, obviously the load will be shared by the pedicles. Patient is not able to sit. And patient was morbid, so they couldn't go for a higher surgery. But I'm just trying to share, choose your patient wisely. Another important story very close to my heart. A good friend and a very jovial friend, and common friend to all doctors. And he had a nice looking diabetic and kind of a patient, and to some extent osteoporotic. And he came to our, he came with the little of pain. And my ortho friend, he said that he's got a small PIVD one level below, just give an epidural steroid. When I look at the MRI, see it by yourself, and there was a clear-cut fracture here. I told my friend, there's a fracture, and this could be the reason for the pain. And he had a PIVD for sure. There's sometimes multiple lesions there. And that was a primary old disc problem, and there's an acute problem with this. This is the reason for the pain. So he said, I am committed, and let's give a epidural. If it doesn't work, then I'll just go ahead with the. Instead, I'll manage the osteoporosis part and treat this part aggressively, and see what happens. Sometimes you are part of the problem, So I blame myself for that. And look at this. Within 2 months' time, exact dates are mentioned. 2 months' time, it became all flat. Can you look at this? Total waging. Must have been very osteoporotic, alcoholic, keeps falling here and there, but a nice jovial person. He's only 64, man. And then it was a very big surgery done, thoracolumbar area. By the way, this was a higher up place. You look at the D11, so they have to go for thoracolumbar brace area, and they opened the diaphragm and everything. They did a very good vertebrectomy, titanium caging, and lateral screw fixations. Nice, good job. They asked me to do cementing at these 2 levels, which I had to. I cemented this, only then they could put screw there. Otherwise, they were not putting screws. They were not able to put screws there. This patient was 15 days in hospital, 4 units of blood, hemothorax, and the draining hemothorax. He had adhesive pleuritis, and he came out of that with the oxygen and some proteins and all. And 2 weeks in hospital, and I'm not going to tell the expense part. And to be brought back dead 1 week after discharge. So this is something I feel we have to avoid this, where it is avoidable. It was a very pure, clean, one simple cement in here would have been good enough, and patient would have been with us now. So I say we should respond to changing needs, patient needs and times. And it's a very nice quote, sir, which says irresponsibility is no single raindrop believes that it is to be blamed for the flood. So whatsoever is good and bad is happening in this society, we are responsible together. And interventional pain management catching up in a big way, like interventional cardiology. In all kind of these settings, we can really go to these patients. And I say in this era of MAS, the percutaneous vertebroplasty should be in the first line of management in the vertebral body compression fractures, especially in osteoporotic setting. Should be in the first line. And to really have a clear-cut, idea of what the whole talk is all about, this PVP is an interventional technique in which surgical bone cement is injected under local anesthesia via a wide bore needle into fracture vertebral body via pedicle or otherwise, and under imaging guidance, providing increased bone strength, stability, instant pain relief, decreased analgesics requirement, increased mobility with improved quality of life, and early return to work. Now this is coming to the procedures now. This is the anteriorly. When it's cervical, you come from the anterior lateral, like we do disc procedure, anterior disc procedure. When it's dorsal, you would do a costo transfer, because pedicles are very thin and they're straight or sometimes outward going. So the effective pedicle is the costo transfer junction. We go from here, and that's the parapedicular, you can call it. In the lumbar, we go transpedicular, sometimes parapedicular. The transpedicular is the best. Just say cross section. This is the bone, cadaver bone, and we just look at this thing. And this is what you're trying to say. Vertebroplasty is nothing. You have to place your needle into vertebral body without breaching the medial border of the pedicle and filling the cement without cement leaking into the canal. That's it. That is all about vertebroplasty. Remember, there's a basivertebral vein here. So when you're trying to put cement there, it tends to come out. That's not epidural, that's in the basivertebral vein. But philosophy stays. Another point which I want to bring up here is you can angle as much you want to go contralateral with a single needle technique without breaching this. If you breach this, as you're trying to come out, your cement might spill into the canal. You don't want that to happen. Other important thing is you look at the pedicle, angle of the pedicle. It's very, very important. In the dorsal area, pedicles are highly placed and you have to angle below like this. In lumbar area, it's okay. You can go straight like this. And it all depends where is the fracture and what you intend. You plan everything beforehand, not during the procedure. Please understand, everybody. Here is the pedicle we are talking. And our needles is placed at the upper outer quadrant, here, right there. It's about 10 o'clock at this level, and other side is going to be at the 2 o'clock position. Upper outer quadrant, because that gives you a leverage to go inside. When you're trying to go inside from here to here, You don't have to breach the medial border pedicle for simple reason there is a nerve or neural structure next to that. So we're going all the way from here to here. That I'll explain you very soon. This is what we're talking. We have to take this pedicle without going medial to this, because obviously the nerves and canal is there. You have a DRG, nice looking DRG. Your cement should not go in there. No breaching of the medial border pedicle. This is the anatomy. And the intelligent thing is, you start from the upper quadrant here. Yeah. I can hear some voice. Can you just take charge of that, Anamul? And this is here we have a step 1. When AP lateral, I'll come to that again. AP lateral, we keep doing that. And when we go step 2 and we go step 3. Step 3, it becomes safe. Thereafter, you can just fly inside anywhere you want to go. And that is how it is done. The step 1 is upper quadrant, starting point is there, this starting point. AP and lateral, you're doing AP, I would rather say oblique, not AP, say I just squatty view or oblique oval view. When you are at step 2, you always come and see the lateral view, and you are at the somewhere in the middle of the pedicle. When you are next to step 3, which is red light, see green, yellow, red light, and you are just entered the vertebral body. Once you enter vertebral body, you're in a safe place and you can just go inside. This is what the final position is like. You're going from 1 to 2 to 3. This is arrow making. Never ever breach the medial border pedicle. This is important. If you've done so, please readjust your needle. This is step 1. Here, starting. I'm giving a radiological view. And once you do a step 1, there's one point here I want to bring up. Because you are starting somewhere here, there is a faceted nerve sometime. This get entrapped. You're given a local. First of all, you're given a lot of locals you don't know. Patient may come with the pain there because of the facial nerve. So you might have to block the facial nerve. That you have to keep in mind. Step 2, this is midway. We're just seeing the pedicle midway. And we check in the lateral way. You just gone half of the pedicle. And in step 3, once you're breaching the medial border pedicle in this AP view, you're already inside the vertebral body. So there's no worry. That's the best part. And that's the safe destination. You just started and you are inside now. Your needle is already in the anterior 1/4 you saw. That's a desirable thing. We tend to put everything into one perspective. These positioning needle placement, which is very important part of the procedure. Rather, one of the most important part of the procedure is upper outer quadrant starting point, lying like this, and you're lying here in the AP view. And when you are in midway, you're just at the pedicle. You are midway, and when you are just gone into the body, you can be close to the medial border of the pedicle. Here I give you one tip. When you are getting closer to the medial border pedicle, change your bevel towards the medial border of the pedicle so that it doesn't injure the medial border pedicle. I'll show the procedure. So this is about multi-viewing. You in your mind, this should play in your mind. All 3D, 4D should be playing in your mind when you're doing this procedure. And vertebroplasty is one of the very important procedures from that point of view. Although all pain procedures that way is right like this. This is a typical biplane, very desirable, very costly, not possible every place. But this is a desirable thing, and it's a time saving and radiation saving both. And it's a safer also procedure wise. This is, you might go unipedicular or bipedicular. I used to do bipedicular earlier, but lately what I realized, when trying to put a cement through this second needle, first needle, the cement starts extravasating from the first needle, the other needle, second needle. So they're all same cavity. There's no point putting this needle there. So what I start doing is start putting single needle and starting putting cement. When I'm not happy enough, then I start taking my second needle in and do my other work, cement work. Mostly it is good enough if his orthopedic cavitation is there. Navigate the future. People are already having navigation things coming up. Spine surgeons are very happy with this, screw placements and all. Same can be used for the vertebroplasty. This is a beautiful technique. And its radiation safety is very good. O-arm and radiation safety is very good. This is what I said. In thoracic costovertebral junction, is very helpful because your pedicle may be straight, sometimes it's outgoing and your needle will be outgoing. So you cannot manage the single needle. Either you put two needle or you go the costovertebral parapedicular like this. This is called effective pedicle. Understand? Normally pedicle is this. The effective pedicle is costovertebral junction and it increases your maneuverability. But I am against hammering. I don't like to hammer a fracture vertebra. It gives a lot of pain and it distracts the fragments. So I use a drill, put a K-wire first, because it's a very thin pedicle, safety margins low. K-wire is easy, you can maneuver it, you can reinsert it, but not the thick needles like this. Once you are in place, and now this by the way D5 sir, 1, 2, 3, 4, 5, this D5 and D6, this is a doctor patient, is about 75, 80 age, and he had 2 level very bad pain and he wanted a cementing. And this is what I did, look at this, so I'm right in there. And here, this is the first needle, the second needle is going to be there. Over the guide where I put my needle. over the guide wire. So I secure. One point which I want to mention is when I'm putting my needle over the guide wire, always keep in mind the sharp edge of the guide wire should not migrate further in, because there's a heart, lung, viscera and all there. So what you do is, you have a blunt tip needle. So what you do is guide wire. So you take this out, take a blunt one, and now you put a guide wire over this one. I've learned this, hard way. One time it happened, my needle went in, but I was lucky, God was on my side. But it may not be the next time. So please don't make mistakes. This is what I was trying to say. Your major vessels are next to the vertebral body. You have to be careful. This was a very good fill. Patient was very, very happy. Was absolutely pain-free. Sometimes you have to do multiple levels for one or the other reason. This osteoporotic setting you keep avoiding, but when there's one bad fracture, then you tend to help others also. That's how it is. You are trying to manage conservatively. And when you do have multiple ones, you don't do from one side, please. If I did this needle on the same side, they will be fighting on each other. So you do alternate like this, step pattern. So you can manage and maneuver this needle and cement inside. That's how it is. So you do this. Another thing which many people didn't do to more than 3 levels initially, because of the marrow, which gets pulmonary embolism. So that was a very big problem with the respiratory issues. Now people are putting needles and aspirating the marrows first, because if you're trying to put cement, marrow will go in center circulation, marrow embolism will be there. So that you have to look for. This is about the venous drainage. Learn what you're doing. Know the anatomy. Know the whole philosophy. If I have a needle here, I'm trying to put cement, what is going to happen? The cement might walk back like this. That is basic vertebral vein. But if you just change the direction, the idea I'll give you lead is, if your cement is coming in a wrong place, you suppose it's one of the vein here or paravertebral vein, just give it about 15-30 seconds. Your cement inside the body is at 37 degree. It hardens faster, and then it's non-flowy. The one which you're injecting is a flowy cement, will become non-flowy, so that will plug the vessel actually, and then you can just change the direction of the needle and start injecting further. But in the meantime, when you're doing this maneuvering about wait of 30 seconds, your needle should be clear of the cement. If your needle has a cement, that will also get clogged, and it's become very difficult to change the needle. I have a technique I might tell you if I have time, how to change the needle, vertebroplasty needle, during the procedure. Some people do intraosseous venography, yes or no? We have to understand. Some people feel very happy, they want to put in a dye, they see all these veins and all, and they feel happy, okay, saved. But look, there is a black bone now. Now where to put cement? So that was technically a problem. So there are 2 tips to this. Either you don't put a kind of a venography, intraosseous venography, dye, or you do is, if you put a dye, if it is gone somewhere, like sometimes the balloons get burst, kyphon balloon get burst, and his whole bone is black now, you do is a lot of saline wash. The bone is again to the tune of this, and then you start injecting cement, because you want to see each drop of cement you inject. You don't want to miss on any drop which is going into the vein or somewhere into the spinal canal. So don't miss on that. That's very, very important. Like in some patients who have been complacent. This is complacency. If your cement is flowing into the vein and is still injecting, that means one is cement is too fluidic, number one, or number two is you are too complacent about the things, and your CM is not good, or something is not good, or that day is not good, and it has gone into the heart. In some patients, they have removed from the heart, it has gone to the lung, there has been a death. So please be careful on this. It does happen, please. Benign cement leaks, all of the 6 walls of the vertebra, I'm not worried if it is interiorly in the upper disc, lower disc, or sidewise. I'm really not much worried until it's going in the vein. Let it go around, but it should not come into the spinal canal, and that's where the malignant leak is all about. It shouldn't come into spinal canal. If it's coming spinal canal, it's not good. Please understand. And it might need another big surgery there and then on the table. You might have to do laminectomy, you might have to do a cement removal depending on how much has gone in. So we have to be very, very cautious. As soon as start coming back, be very vigilant of cement anywhere coming into the epidural space, because there could have been a posterior dehiscence. So that you have to be careful. There are some complications. 1.4% will have an asymptomatic pulmonary embolism. Not good, but it does happen. And 0.7% will have a nerve irritation, because it might leak out paraneural area, and it can be managed with the local steroid later on if need be. Or there and then if you already seen the cement coming into the root area or patients complaining. But rarely you need another surgery for that. The OT preparation, the most important thing is, except all of the things which you know of, the other important thing, keep the OT at low temperature, around 20 degree. Keep cement and the radiopaque powder and liquid monomer in 2 mixing bowls and saline in the refrigerator. Cool the cement before the surgery, before the procedure. or you have a very good vertebroplasty cement, that way. And this is the position of the patient. Yeah, this is the position of the patient. I like to keep patient in little extension and little traction here, because I want to offload the anterior column, because I want to elevate the anterior column. So that's the important thing. And absolute sterility is important. Always keep spare needles. Don't depend on single needle. Please, n number of needles I keep. I have a set which got 20 needles ready with me. All trocars, because pushers and trocars, because cement may get clogged in here, and all those, all this cotton gauges and all for the pushing, because you can't push sometime. And the pliers, rarely I use hammer now, pliers. And this is the stab knife for the skin and for the cement. And this is dye and the LA. This all should be there in the set ready. And I use 2 ml syringes. Look at this. I don't use kits, I use syringes. Here I'll explain you. Another important thing I want to mention is a big bowl with a ice cold saline, and this should be there. And this is what I was saying. N number of needles lying in here with the trocars. I'm always keep everything spare. A big set. Cook needle is good. It's a diamond tip needle. It's very sharp, but very careful. Once you're inside the bone, you have to be more careful. You don't want to go too interior. This is important. And then the injection devices and all. This is there. Another thing is, there are different kind of needles are there for the reason that you can screw in, you can go easy, smooth, and the side holes for the injection cement and all. This is there. And this is the angle cannula, which Dr. Diwan was talking the other day, is very, very useful. You can do an angle cannula and do the targeted cement delivery at the area where there's a crevasse is there. Some people like Dr. Gore is using Gore hook, and which can be made to go lateral, it's a articulated hook which can make lateral, and you can elevate the end plates and then you can cement inside. These all are innovations, beautiful innovations. Yes, there are cement delivery kits. They are available with the companies, but they're dirt costly. I may say it's about $1,000 approximately in India, and in USA and other places maybe 2,000, maybe more. So this is something little cost additive which you can curtail. So you have a good cement PMA which works very, very low cost, and it has got a high curing temperature which is good for denervation. That's take care of part of the pain. It is good radiopacity also. So we have been using PMA very often, but lately they are very good cement is coming. It's calcium phosphates or composite cements, and cost is definitely high, but the curing temperature is low. That is it, and is again nice radiopaque and highly compatible. There are some good cements now which is coming, which is osteoconductive, and the bioabsorbable cements. So what is happening is, when you're putting cement inside, it goes into trabeculation. It doesn't move anyway. It is part of the bone now, not like PMA. Sometimes it goes like a block. So it's not a happy thing sometime, and it's osteoconductive. This keeps getting absorbed, and the bone formation keeps happening. Ideal for young patients. And this is calcium phosphate in young patients, traumatic fractures, or in prophylaxis by adding chemotherapy agent or radioactive isotope in the cement in the tumor setting. This is another doable thing, which is new development coming in. Cement mechanics is vital. When you start your cement, I start a stopwatch here when I start mixing cement, and there's a dough time. And once the dough time is there, there is a working time which is about 5 to 10 minutes, depending on cement to cement. Some cements have 30 minutes per working time. I'm not very happy on that, but again, because they tend to stay fluid. When they stay too liquid, too fluidy, their chances of leakage is higher. So I want cement which is neither too fluidy nor too viscous. They start getting harder by this time, stiffer and stiffer, and it becomes very problematic to inject this stiffer cement. And the big problem is, most of the accident happen at this point of time, when you're trying to pressurize cement against a needle with a full pressure, and suddenly it gives in, and the cement has gone into the canal. So that's the worrisome. Cool the cement, cool the saline. That's the whole point. And here, when I'm mixing polymer and monomer, I do add antibiotic sometime. I do add a dye. This is my own innovation, because to have a very good visualization. So what I do is, like in PMA, you don't have good visualization. Cortis is very good visualization. What I'm doing is, I'm adding the dye instead of barium sulfate, my own Omnipec dye, and I've got a cement sample which is 15 years now with me, and they're as hard as they were 15 years back. With me, it's a ex vitro, not in vivo, vitro. In vivo, obviously they must be as hard, And I did a presentation, vertebroplasty, extended indication with procedural improvisation, in one of the world congresses. I presented this concept of mine, the guide wire and Seldinger method, as well as the dye for opacification. And what kind of anesthesia we have to use? We have decided for the procedure. is going to be local, mostly we use, or near left, obviously a welcome thing. Generally is mostly for the surgeons, reserved for the surgeons. We are doing a kyphoplasty under anesthesia. But then you have a neurological monitoring in place. Otherwise, don't do it because it can be nasty if it leaks. That's the point, you know. So that's how it is. The procedure part is sedate the patient. Oxygen has to be there, your nasal oxygen. Vital monitoring is there. Prone position, adequate padding. Bladder should be empty. Patient should not be. Should be ready, you know, to manage the bladder part if it takes a little longer, which normally not is the case. Vertebroplasty is a very fast procedure, half an hour max. And then obviously fluoroscope view. You have to see all fluoroscopy view, AP, oblique, lateral, before you drape the patient, I would say rather. And total aseptic precautions of the all major surgeries, and clean drape and do measurements. I do all measurements beforehand, as I mentioned you. Localize symptomatic material. People have done wrong level. Please, friends, it should not happen. Count your fractures. Sometimes it's not so obvious. Count the levels, you know, the fracture one, and then you only put in. Confirm it in AP, lateral, oblique. Go up and down. Either go to the ribs or you go to the sacrum and then relate. So what I say, third last or fourth last from the sacrum. I don't say which number. Please understand. It's the third last, fourth last, or fifth last. I go accordingly. Until is an obvious fracture. Choose your approach, either transpedicular or peripedicular. Anesthetize skin subcutaneous right up to the periosteum. That's where your facial nerve is taken care of. I was mentioning earlier. Skin stab, very small skin stab, and you don't have to stitch. You can just put a bandage there. Insert K-wire. Normally I tend to put K-wire. Until is very osteoporotic and my vertebroplasty needle goes in smoothly. And then I just put my vertebroplasty needle over the K-wire. So put the procedure in a pictorial way. This is what my starting point. Putting the K-wire, and over the K-wire I put my needle into the vertebral body, and I just use bevel to the advantage. Again, remember, your bevel should be towards the medial side to medial pedicle, and that's where it's going to brush past the medial pedicle instead of injuring the medial pedicle. And once you're inside the body, you might have to go anterior 1/4 or anterior margin depending on what is your desired thing. Anterior 1/4 is good enough. And that's where once your needle is in a position, only then you start making your cement. Because your stop clock starts right then. And all this paraphernalia should be ready. Multiple needles, multiple pushers, and all those things. And I put a dye. And this is vertebral cement injection. I use 2 ml syringes. And cement is to be injected in the lateral view. And it has to be live fluoro view only. Remember, please understand, live fluoro view only. No drop of cement is to be injected without a live fluoro. And that is how it starts. You start from anterior. Keep going posterior, keep adding cement in, stop somewhere in the posterior 1/3 or 1/4. Please, it's so kind of tempting to put more cement in, but that's where most of the accidents are happening, even in good hands, until you have a very good view of the CM. This is what is said. Done lateral position, don't over inject. See, underfill is better than the overfill here. In dorsal level, maybe 2-3 cc, depending on fracture morphology and cavitation. Please understand, very important, this is not in specific generalization. The generalization. 5 to 7 cc for lumbar vertebra, again cavitation and fracture. And depending on if it's leaking or not, use viscous cement. It's good to use little harder cement because it doesn't leak out. It stays therein, and especially in the kyphoplasty. And when cement hits posterior 1/3, stop it. And then there are issues. Cement does go here and there. 67% time cement will go one way or the other wall. Whether it's up or below, anteriorly or sidewise, no problem. It shouldn't go posteriorly. That's the only point I'm trying to bring. Global fill is possible. Look at this, but it's not desirable. It's doable, but not desirable. Please don't do this. I'm just trying to say, please don't do this. Very important point here for my friends who are doing it. They would understand what I mean. When you remove the needle too early, your liquid cement will track back through the track you made. It's a cement nail now lying in the body, which is very, very painful, and patients keep complaining. Or you make it too late, in the sense you waited too long, and your cement inside the needle and cement inside the vertebral body, they become one piece. And when you remove the needle, your cement, you see there is a nail hanging outside the skin from here. So it has happened with me, and it's only when you're complacent, only when you're not conscious of this and you've done a very good job, take needle out and suddenly find there's a nail hanging outside the skin. Oh, now you're removing this nail is a hell of a job. This cement inside the vertebral body. You have to break this and take this out. So what I do, and I always tell my assistant to be very cautious along with me, as soon as I'm out of the pedicle, what I do is I just break my cement, what is inside my needle and inside the body. So they are not in one piece now, and take my needle out. That's what I do. The mechanism of pain relief, why we do vertebroplasty, how is going to do the pain part, Relief is by virtue of cementing the fragments, obviously. Then there is a thermal neurolysis because of the heat which is coming, heat of polymerization which is coming, right? And then there is a washing away the nociceptor chemicals. Neurolytic action of the liquid monomer itself is to some extent neurolytic, mild neurolytic, and then allowing early ambulation. When soon as the patient is cemented, patient start moving around, so pain of the bed rest is gone, early mobility, immobilization pain is gone, and it is opposing the osteoclastic activity. So that's the way it kinds of help. There are few patient examples. I call it a quick fix phenomena. Patient fell in a Gurdwara early morning and he had a fracture, and you look at the burst fracture and is diabetic and is about 65 or so. Same evening I put a needle inside, just did a cementing underfill, not overfill, imagine, and upper border, this upper border fracture, and that's what it is. Next day patient is back, and next week is back in Gurdwara. So this is the beauty of the procedure. I call it quick fix phenomena in right patient, again remember. Or you can these days with the teriparatide, denosumab, you can manage this. In a traumatic fracture in the polytrauma setting only, I would like to do a cement fill and that to underfill. Only kind of sticky, make them sticky together and put them together. That's all. Don't overfill. Leave it to the nature rest of the job. If your osteoconductive cement is much better, which I told you. And this is a younger patient. He had a polytrauma. Look at the head injury. And he had this L5 fracture. Neither patient nor surgeon wanted a surgery. He had a very bad head injury. And then we did a cementing, and it was long back. 2000, by the way, 2005. And this is another polytrauma patient. We were doing a fracture humerus car accident, and we found she has a back pain. Look at the body, L1. This is a stable burst fracture L1. Stable why I said is because posterior column was intact and height was kind of preserved, but it's an acute fracture, and that is, it is unlikely to, look at this thing. I'll give you the history why I said so. And look at the fracture void, very big void. There's a little retropulsion, that's a risk factor there. And this is what we cemented. We cemented, and this is cement, and even glues the fragment which was there, retropulsing fragment which is there. Look at this, retropulsing fragment is glued in there, and the canal is safe now. So this is very important. Then you have to be very proficient. This was 2006, by the way. So you can take a calculated risk in subset of patients. Calculated means you have to be good. You cannot take chances, I said. Calculated risk, not chances. And this is that time. And this is a smile all over. She had a very bad, very, why it was important to do a very bad fracture of the humerus and head also. They put a 3 K wires in here, and she had to sit for the gravity, and because of the fracture she was not able to sit. She was a little obese, and she was age about 60, osteoporotic setting. Her sister is osteoporotic, her brother is osteoporotic, there is a family osteoporosis, and that's why we had to do this, and we could pull out the very good result out of this. This is her sister. To tell you the truth, she had 1 fracture, didn't go for cementing. Advised, she had 2nd fracture, again didn't go for cementing. Look at the very risky, fragile fragment which is there. This is a walking bomb. If it goes back, transaction. And we keep seeing these patients. It's not it doesn't happen, it does happen. It's a nasty thing. And look at the unstable kind of thing, angulation coming up, and there is a osteoporosis must have been setting in. Look at this, tooth level I cemented for sure, which I had to. And third one I just put in a trial cement, and look at this, how much cement has gone in. That was the next one to go. So we don't do it normally with the cement in fracture sometime, and these are the patients you can pull out in time. Over-conservatism can be dangerous. This patient was nice, 59-year diabetic patient, little alcoholic, and he was put on conservative management. But there was a miss. Miss was that in 2 months, 18 days, patient was not checked for the increased pain and all. I could see 1 X-ray in between, and there was a doubtful fracture at another level. So get an MRI done. Look at this. Real story, real life story. And there's the original fracture, and there's other fractures which has come up. 6 levels gone in that 2 months, 18 days, and he was left alone. Don't leave your patient alone. Keep a continuous workup, keep checking for the other things and problems in patients, especially patients complaining. So it's complacency again, and it's overconfidence. Okay, it will be fine, So what has happened is, patient has got 6 level gone, so I had to do all 6 levels because they all must have been painful. In one go I could manage, in one sitting it took me 3 hours, and that was a world record that time. It was 2010 I did. Nobody did 6 levels, frankly they did 1, 2 or 3 for simple reasons that it takes time and the marrow will get aspirated and you don't get so many fractures in Western world in one go, one time. They are not neglected like this, like it has happened in this patient. And this was a patient. He was not much. He was 59 only. Happy patient, satisfied doctor. So sometimes vertebroplasty outweighs the conservative management in such scenarios. Never be overzealous with the vertebroplasty or with the conservative management. You have to balance out. And I did a presentation in the World Congress in 12 in Miami. And dear Rex sir and everybody was around, and he was very appreciative of the 6th level. Another patient, I was given a call in the ICU. Patient was on ventilator. Call was, is the patient ventilator, he's got a spine fracture. I said, why is on ventilator? Because he was put on morphine and he had a respiratory problem. So look at this. Now patient ventilator because he was given morphine for the pain. Now one more important thing is in dorsal level sometime there is a vertebral fractures and patient doesn't present with the vertebral fracture or pain. What happens is when there's a pain, there's acute bronchospasm, especially in respiratory patients who are asthmatic. So patient lands into the hospital with the acute bronchospasm, then the pain. And patient treated for the bronchospasm, then the pain. Please understand these. I've seen these patients quite often. In the dorsal vertebral body fractures, presenting as a respiratory issue instead of the pain issue. Pain brings the spasm further, bronchospasm. So what I did is, there's a fluid by the way. Look for when there's a fluid, look for the tuberculosis and other things. And that all ruled out because in tuberculosis there's dirt lot around. So that has to be differentiated. And the fluid, you aspirate the fluid, a straw color fluid comes out like a ganglion, and you put a cement back in, patient is walking next day. And this was a diabetic patient, he was diabetic retinopathy, almost blind, and that was it. And he's in the OPD after the procedure, in my OPD, one of the OPDs. So you give them their life back from the ventilator. There are sometimes vertebral body fractures, they are painful. This patient was 119 kg, by the way. So I did a cementing on this, made a bridge, patient is back to life, patient started doing exercise, routine activity, went back to 84 kg or something, 89 kg or something. So they're back to life. Another such patient, the wife got the patient to me, and the complaint was he's become addict with tobacco and pan prog. And why is addict? Because he's having a lot of pain, back pain. He was walking, by the way. It's a teether cord. Patient was able to walk, but gallbladder was gone. He was catheterizing himself and he was manually removing his feces. And by the way, please understand, my friends, the surgery has been done. Look at the laminectomy. Laminectomy has been done. But there was a miss. This lamina, this was not removed, which is compressing. The cord is getting tethered between the retropulsing fragment from the fracture vertebra and the lamina. And cord was getting tethered. So that's why, and imagine when there's black bone means this is collapsing. There is an active fracture going on, meroedema. And this is 1 year after fracture, by the way. And one surgery was done 1 month after the fracture. And meroedema. And ever retropulsing fragment. For same reason, with all that due risk explained, I did only anterior vertebral reconstruction. Only anterior vertebral reconstruction, just to take the load off the posterior fragment which was there. So it's not, I don't advocate others if you are not well versed with the vertebroplasty technique. It's very risky. In sacral fractures, there are lines, weak lines, where the fractures tend to happen. So you should realize that it does happen in insufficiency fractures or hemangiomas, very, very common, or with the mats. And you have to help the patient. And this is what it is. You go into sacral ala, put a needle in there, cement them well, and you're going contralaterally. Remember, it's not, you're going ala. Ala is a place you can't do a cementing in the canal area. That's important. Sometime, if you have any doubt about the root being involved, put the needle inside the floor room, take the patient to CT room, and now at the CT room, you just put your rest of the cement in, and now I'm putting my cement in, coming contralaterally like this. Avoid the roots, otherwise your roots get involved, it can be getting nasty here. But if you don't do it, again, it's a very risky thing, painful thing there. Even cervical area can be cemented. Look the needle in there, put the needle. This is, by the way, 2E needle, white bore 2E needle, and you put a liquidy cement which you tend to stay inside the vertebral. It's one of the hemangioma kind of scenarios, and you put a cement in there. I had a patient, he had a CVA, and post CVA had a fall. He was on all kind of drugs for 19 days in the hospital, all kind of drugs. He used to have a fall and he broke his C2 here. And that's why I did a transoral, run the anteriorly, I put a needle in there, put a little cement just to glue the fragment, not much, and put the patient on the otherwise conservative management. And this is after a few years he came down to me and it was all good. I lost the track of the patient. I thought maybe he's there or not. But he came down and it was nice to see him. So your good work sometime, shows up. Now this patient was sent to me with the vertebral body fractures for cementing. Please understand, by a doctor to me for cementing of the vertebral body. There's a fracture here. Is it osteoporotic fracture? Please look at this. There's a lesion here. There's a lesion here. you get the scan done, and if you get either the contrast MRI or contrast CT, or you do PET scan or bone scans, and you find these lesions coming up. It can be osteoporotic, it can be POTS and MATs, all these things, they show up well. Do have to do a little more testing, do have to do a right treatment on given subset of patients. If it is MATs, obviously they first go to the cancer center, they come back to me. I am the secondary physician for this patient then, secondary doctor. The primary becomes onco physician. You better take a biopsy. As if you have any doubt in given subset of patients, for tuberculosis, yes, we do aspirate and biopsy. Even for the MATs, you should take a biopsy. Sometimes biopsy is not done with the forceps. There are some kind of a cutting edge needles are there which can sheath. This goes through this and it cuts a bone and then takes a bone fragment out. And you take a biopsy, and it's very, very important to take biopsy. Or you may be litigated sometime. Please understand. Now this patient had a fracture, and by the way, he had a CA lung. And it was a very painful thing. So I did an intercostal block, then paravertebral block, then epidural block. Then lastly I did an intrathecal block. I'll show you like this. And his pain went off, absolute zero. He said, get my CT scan. I said, why? He said, my cancer is cured. So this is the beauty of some good pain treatment. Intrathecal urolosis, I'm very big fan of this, especially in this torso pain. But yes, the pain stays and the problem there. By the way, the pain is taken care, but the problem stays. So I'm doing a cementing. This is C1, C2, C3, D1, D2, D3. So I did a kind of a cementing in this patient. This is 2008, right? So and it's good. It's always you have to reinforce. But if there is a patient who's got low expectancy, don't do it, or do a palliative. If it's high expectancy like myeloma, do a full work, but carefully, no leaks. Because in MATs, there are 5% chances of semen leak. In otherwise osteoporotic setting, only 1% chance of semen leak in the spinal canal. So you have to take that important thing. This is which I've been doing for some time, but I have seen a very good article lately that you can really ablate the tumor. So what I used to do is put 2 needle inside, put 2 RF needle and do a bipolar of the RF, or bicycloplasty like we do in the lower disc here. I used to do a bicycloplasty kind of thing inside the tumor area. So kind of burn the tumor, put semen to some extent. The tumor used to get kind of a shrunken over a period of time. That was a good thing. And this was the article which I read. Very good. Treating metastatic spinal tumors with targeted RF ablations, and along with that, RF ablation along with the radiotherapy, RT. So they comboed RT only and RT and RFA. They found better result with the RT and RFA, 93% overall response. So that is something you have to do, RT and RF. RT alone is not enough. Now few special cases about kyphoplasty which sir was talking. Sir, am I good? Hello, sir.
Yes, you are very good.
Sir, thank you. So I'm on to your love topic, which is what kyphoplasty. So I'm on to that, sir. So I'm just
Yes.
It is a little lengthy, but it's quite comprehensive and inclusive, that way of the intricacies and the side lines we don't talk normally. This is about balloon vertebroplasty, or we call it kyphoplasty. So that's the philosophy. The philosophy is that you tend to gain height. The anterior column. The anterior column reconstruction is there, you gain height, the cement volume is increased, all those kyphotic angle is decreased, so that way is better. But there's a very good study lately which says there's not much of change in quality of life, there's not much of change in the pain scores between vertebroplasty and kyphoplasty. They are parallel. Other things are definitely better, but yes, kyphoplasty is a little costlier. But when you say you make the angle better, chances of loading the other vertebra is less. That's my plus point for the kyphoplasty. If you want, you can go ahead with the kyphoplasty. The difference is important, is under LA. Some people do it GA, I still do it under LA. Can be performed anytime after fracture, and is less than 4 weeks after fracture, because then the bone tends to get harder and the balloon doesn't inflate. But height restoration only with the positioning which I told you, extension and traction. I use it very, very often. I went to Hopkins and I saw people missing on that. So I gave a word to them, and then that was it. And that's the vertebral height restriction with balloon. Obviously, putting balloon, you don't have to do a extension part. Still, it aids to the balloon expansion. And injection under high pressure. That's where the leaks are more often. That's where it is a problem. And injections are low pressure because you made a void and you have to fill the void. You don't have to. And you can use a viscous cement, thicker cement. That's the point. And then obviously the cost part is there. This is what the whole thing is, balloon and kit and all those things. You put a fine needle first, over the fine needle put a guide wire, and after the guide wire you put a thicker needle in there, which is the kyphoplasty needle there, and through the kyphoplasty needle you put the trocar in there, make a space in the bone for the balloon, and then you put the balloon inside. After you balloon open the vertebra or fracture, thereafter you put your the plungers with the cement. This takes about 1.5 ml cement, remember. So you keep putting every 0.5, 0.5, 0.53 markers are there. So one plunger will take 1.5. So you fill 2, 3, 4 plungers depending on how much you want to inject, and you start injecting. But once you're injecting cement, remember, cement should not fall. When you make it vertical towards sky, cement should not flow out of this plunger. It should come out as a vertical thing. That should be the consistency of the cement when you're injecting inside the vertebral body. You want to make it a little harder than fluidy. And that's what the balloon inflation device is there, because balloon needs, and this can go up to 700 psi, remember. So we can go 300, 200, 400 depending on the bone to bone or cavitation to cavitation. This was saying, you go inside first, bring out the sheath needle and take a trocar now inside the driller inside, and drill the bone, make a space for the balloon. So you have to drill adequately that your balloon goes in smoothly. Make your balloon stay at the right place where you want it to be. Please understand. You shouldn't go on one side or the other. You shouldn't go too anterior or too posterior. It's important. You have to keep balloon right place. And once you inflate the balloon, more it is inflated, more is occiput cavitation, then it's empty bone. You're meeting with empty bone. And this was by the vertebroplasty. This was meant for the kyphon inflation. Very important lead, when you're inflating the balloon, please make your balloon stay at one place only, because it tends to migrate in and out, right to left. So balloon inside the bone, what I'm trying to say. So make it a point that it should not move inside, because what happens is it takes a path of least resistance. So there is a problem. Like this is ideal balloon placement. You have AP view, which is nicely well central inflated. In lateral view is anterior 2/3. See, posterior 1/3 we are avoiding, because there may be a fragment which may get retropulse. So anterior 2/3 only you are trying to do this, and you just put cement thereafter. I mentioned you, when you put a cement inside, consistency should be good enough. It should not just flow like this. It should just be injectable, But don't wait too long, because if it hardens inside the needle, you can't inject inside this sheath needle also, vertebroplasty needle. By the way, this is my technique which I'm going to mention very soon. I put a epidural safety balloon from a segment or 2 or 3 segment below. I'll show you that, and that is how it is done. One thing I just forgot to mention, and I must mention now, so you make a cement in the cold saline. Why? When you make a cement in the cold saline, your cement outside is about 15-20 degree, ice cold saline rather, and it doesn't get hardened faster. It is a differential hardening with the differential temperature. Inside body is 37 degree, it hardens very fast, and outside is about 15-20 degree, it stays liquid for longer. So you make use of the differential temperature to your advantage when you're injecting inside. Inside will get harder, outside will stay. Again, the needle is 37 degree, remember. It might choke the needle, so you have to be careful about that part. This is very, very important trick. Now this is you make a void first and then fill the void. Simple. That's life is easy. Sometimes one balloon is not enough. You might have to do 2 balloons. Put 2 balloons, cost adds there. But yes, if it is required, you cannot manage to single pedicle, go 2 pedicle and cement both sides. Now this is, there are some issues with the balloon. It doesn't inflate. You see, it's a collapsed bone. It is not inflating. The bone is already closed. It is not alloying. It's okay. You cement this much only. Bone is already hardened. Or the balloon is, I said, ectopic. I mentioned you earlier. Balloon may go place. It may go backwards, frontwards. You make one space. Next time when you're trying to inflate balloon other place, it will keep going same place again and again. You don't want that place to go. So you have to hold the balloon in place when inflating. Very important. And if you overinflate, the bony spicule might be there inside, which might rupture your balloon, and your whole bone may go black. The dye may leak out. It's okay. Take the balloon out, do a wash. You done your job well. Do a wash now and start injecting cement. Do a saline wash before you inject cement. Again, I say there are new systems which are there, the expendable systems, and this is the jack which is there, which doesn't depend upon the eccentric ballooning. This goes and inflates the area to your choice. So this is a very good technical device which is already there. Or there are some system, VBS system, where you have a stents. You inflate like stent, like in cardiac stenting. You inflate the stent, like a stent is there, you inflate the stent, now fill the stent with the balloons. With the cement, by the way, sorry. And it stays there. Same thing you do with the vesselplasty. You put a needle inside and you open up the vessel. What initially vesselplasty was bad, because there was, it used to be like a ball, glass ball. It used to migrate here and there. And there have been cases of it migrating. They did a very intelligent job. They did multi-puncture in this balloon. multiple punctures. So when they're trying to put a cement through this balloon, it comes out like a bacteriophagus coming out, or like a thorn seed, and it kind of fixes itself into the bone. And some cement leak outside also helps the trabulation part. So that was a very intelligent thing going on. There are few patients where you have the cord is getting compressed, patients in mats, it's a widespread mats, expectancy is low. Nobody wants to fix these patients because obviously low expectancy and morbidity. Sometimes it's a morbid patient. Like this patient is very morbid. They are unfit for surgeries for that matter. You keep getting these patients. Patient doesn't want surgery, surgeon doesn't want surgery, but it is required. Some stability is required. In such scenarios, I have devised my own technique, which I show you. I put a balloon, sir, a space or two from below. Through a white bone needle, I put in a balloon, I take in empty space, and there's a cementing going on here. I'll show you how I do it. This is the one where I'm trying to do cement in there. There's a fracture void. I put a balloon in empty space next to the posterior cortex, and I just inflate the balloon for two reasons. One is it stabilizes if there is any retropulsing fragment or loose fragment for that matter, and as well as it might plug the leak if there was any to some extent. And third very good advantage is it is visualization of your epidural space. I can visualize my epidural space or posterior cortex for that matter. That's the best advantage of this balloon. And once you've done the cementing, you deflate the balloon. This is 6 centimeter balloon, 6 mm inflated, and you give it back to the cord. Cord is very happy and patient is very happy. At the end of the procedure, I do a myelogram. Check myelogram. I want to have a good night's sleep. I want to be everything to be clear on my table. At least I'm sure I have not done something wrong in these patients. Same thing I kind of devise, same device which you're seeing now. I'm able to help these kind of patients, dirty patients, very fragile patients, and fragments which I could cement, and they're back to life. Good number of patients are back to life. Otherwise, they would land for a bigger surgery which is either not doable or not desirable. Now this patient, she's 86, heavily comorbid, and totally inoperable, and in problem. Look at the cord getting compressed in there, and she is already getting symptom of the pressure on the cord. And look at this, and a very, very daring attempt which I did is, I did a kyphoplasty in this patient, try to inflate as much I could, anterior inflation only, anterior column, don't come posterior, already there's compromise, anterior column inflation, with the balloon in place, I'm doing anterior inflation and did the cementing inside. And this was 86, look at this 86 lady, and this is, and she was able to walk. That's the beauty, that's what you want out of this patient. Look at this, vertebral plana, sir, bone, this is disc to this, there's no bone, zero bone, air, you have air phenomena, and the bone formation is there. This is a vertebral reconstruction, I would rather call it. It's not a vertebroplasty, vertebral reconstruction. There's no bone in here, and you construct the weight bearing column there. So your load on the posterior retropulse fragment goes out, and patient is back to life. Old people, sometimes and they really need your help, they need a hand. So sometime if you're proficient enough, you can go ahead and do this good to the patient. I presented this in one of the World Congress in 2016. In the World Congress, I presented this epidural balloon neuroplasty and foraminoplasty, an innovation. That I presented that time, and it was very well applauded in 16. So there could be sometimes persistent pain after stabilization. What is it now? We should know in and out, I said right in the beginning. Wait couple of weeks, it may time for delayed analgesia. The facet syndrome or SI syndrome may be coming up, or maybe it is there coincidentally which was missed. The costovertebral tenderness is there because you might injure costovertebral joint when you're going through this ligament joints, and sometimes rib heads are also fractured. Please know it. And even pedicles, people have done pedicle fractures. Please know it. I do pedicle screw. If I fracture pedicle, I put a pedicle screw in the sense cement screw. When I come out of the pedicle, I leave some cement there. If it is osteoporotic, if it's normal patient, I don't cement pedicle. And unrecognized pathology, do re-image, do another shot, another CT MRI, and a new fracture may be there. Now this I was trying to say, or maybe incidental pathology. You're looking at this, you're missing on this. So this may be patient's problem. Patient may be symptomatic because of this, but this was emergency. You had to do this because this can give a pressure on the cord. You've done this, but missing this is not good. Or sometimes facet problem is there. You do a facet denervation and patient's taken care of. Recurrent pain after stabilization, very good. Reimagine, new fractures. It is said the 12% patient will have new fractures in 1 year time, of which 66% have adjacent level fractures, and 1/3 will have a distant level fractures. Please understand, distant level fractures, not contiguous fractures. And of this, 2/3 will have in 1 month time and 1/3 within 1 year time. Almost all of them will have in 1 year time. Because the disease is ongoing, treat the osteoporosis, not to miss an osteoporosis. You done a good cementing, nice level there, another level come up. You will have to have. Sometime you can manage with medication. You don't have to cement all fractures. You can just do with medical management like this one. You can do with medical management. There would be situation you want to cement, it's okay because patient desires the cementing. In totality, last few slides, sir. The pain scores are really good ones. After 52 months of follow up, pain scores are better. Patient can manage without braces because brace is not good to keep, and their quality of life improves dramatically. There are a good number of patients, 84 patients and all, and they are improved quality of life. And yes, you get thumbs up from the patient. This is one of the patient, old patient who had 2-level fractures, came from Nepal, had a cementing. This is post procedure, sir, just outside the OT, patient standing. That's a beauty. So in conclusion, vertebroplasty is in experienced hands and in appropriate patient selection. Very important to do a patient selection. Is a safe and very efficacious procedure for the treatment of pain and disability associated with the osteoporotic compression fractures. And the procedure has a relatively low complication rate, and with a very high success rate. But you have to be very proficient in your this ratio what we are talking now. And vertebroplasty is a palliative procedure. It does not correct the underlying disease. Please look at whether it's infection or MATS or osteoporosis. All three need treatment in their own right. What you've done is stabilization, and medical management of osteoporosis or malignancy must continue, and it should be there. The best way to define your future is to design it, and I would say do it designer's way. Live by choice, not by chance. And we do these workshops, in India, sir, with your blessings and all. We're doing workshops. I did FIPP and CIPS both, and I'm trying to take a kind of a charge and train as much I can, and as many people go for FIPP and CIPS and they get trained further on. So it's always desirable. This is the one of the workshop pictures, not one, but I've done 16. The 17th was due, and this got victim to the corona, sir. It was 17th, 23rd April was due for next workshop, and that is gone. We'll see as and when. It's a live on patients, by the way, sir. Live on patients. If any questions, I'll be more than happy to answer. I think I've taken a lot of time. But I want to say, pain relief is a human right. This was said again and again in Miami, in Montreal World Congress. And it is our duty, it is our utmost duty to do this service to the humans. And when we're doing this, we're not doing only for our future generation. Please, when you're talking about the vertebroplasty or kyphoplasty, senile osteoporotic, we are trying for our past generation, for our parents, grandparents. It is an equal duty of ours to help them as much we can. And I'm thankful to my family, my beautiful wife, Gaini, and my kids. Both are in Toronto. In Canada now. He's gone to Vancouver, he's in Toronto. And who could spare me to do all this work, which I want to. Thanks, my friends. Thank you, everybody, again.